Oh, cool.
Well, I'm sorry. Hang on just one moment.
You are okay.
No, it's still there. I don't know why I can't find it.
Look great, Jourdan.
Oh, thank you. So do you.
Oh, there we go. Okay, I think we're ready to get started. I just couldn't find my Excel spreadsheet here. So here we are at 12:30 and ready to get started again with our next presenter for the 2020 Celebration of Scholarship. These are poster presentations today. And so our next presenter is Jourdan Greene, and Jourdan is going to be presenting his work on the efficacy of aromatherapy in adults with postoperative nausea and vomiting, a literature review. So we'll turn it over to you, Jourdan.
Awesome. All right. So as you can tell, I did a literature review over the efficacy of aromatherapy in adults with postoperative nausea and vomiting. And just to shorten that up, I'm going to be saying PONV for the rest of that, or at least try to. So what is PONV? PONV describes nausea or vomiting or retching in the immediate 24 hours after surgery. And what makes this important? So it's estimated that 10% of the population will be having surgery and undergo general anesthesia, and 30% of those individuals will result in having PONV. Additionally, 1% of these individuals will need to spend an additional night in the hospital because of complications related to PONV. However, in individuals that are high risk for PONV, this percentage boosts up to 80%. So what does that ultimately mean? Extra time in the hospital can have a significant effect on the patient. This can mean time away from the family, home, work, and can impact the patient financially without complications. In 2010, the average hospital stay across the United States was $9,700 a day. And in patients with PONV, this can mean an extra night stay, which means extra pay, not including other complications related to it. Hospital reimbursement is often based on performance indicators such as patient satisfaction, and if this is low, hospitals may not get reimbursed, leading to absorbed costs. One of the quality reporting systems that hospitals use to determine reimbursements is the Hospital Consumers Assessment of Healthcare Providers and Systems, or what we all know better as HCAHPS. This is a survey that allows patients to evaluate their care and satisfaction, and once patients are discharged, they have the opportunity to take this survey. A variety of quality metrics are asked, including ID bands being checked before medication administration to how well pain was managed. High scores lead to better reimbursement from insurance companies for hospitals. However, HCAHPS does not assess for nausea or nausea relief, but satisfaction is one of the most heavily weighed quality measures. So this means that uncontrolled nausea could lead to more negative scores from patients, which means less reimbursement. Currently, PONV is treated with antiemetics such as ondansetron, scopolamine, and histamine antagonists, and these are used in PONV prevention and relief. However, these can lead to adverse reactions such as rashes, headaches, or even serious complications such as serotonin syndrome or cardiac dysrhythmias. According to the American Society of Peri-Anesthesia Nurses, aromatherapy is, quote, the practice of inhaling vapor or body application of essential oils for relief of specific symptoms. Aromatherapy can be used as a complementary therapy, an alternative therapy, and in 2006 was even included in the PONV guidelines, stating that it was a rescue intervention. Benefits of aromatherapy can include its rapid onset and absence of side effects, and its minimal cost. Aromatherapy may be used as an alternative complementary therapy in those experiencing PONV, and patients state that they would rather pay $100 out of pocket to prevent PONV. For the cost of it, IV Zofran can cost up to 30 cents a unit to $1.37, while essential oils can cost 5 cents to $2.16 per drop. So the purpose of this literature review was to examine the evidence regarding the efficacy of aromatherapy as an alternative or complementary therapy in adults with postoperative nausea and vomiting. A search was conducted utilizing 5 databases that include CenAll Complete, ProQuest Nursing Allied Health Source, PubMed, Cochrane Library, and Google Scholar. 2 key phrases were used in this search, including aromatherapy and adults and nausea and essential oils, and the second key phrase being aromatherapy and postoperative nausea and vomiting, or PONV. The first key phrase resulted in 2,330 articles being found, while the second key phrase led to 5,257 articles being found. The current guidelines for PONV were also searched. These articles were limited to being in English and being published within the last 15 years, and titles and abstracts were screened to focus on only PONV and aromatherapy in adults, so pediatric articles were removed. Overall, 21 articles were found to be valid for this literature review, with one of them being a systematic review, 7 randomized controlled trials, 6 quasi-experimental studies, with the remaining being either literature reviews, case controls, observatory studies, or prospective studies. In the results, a number of themes were identified through this literature review, the first being risk factors for PONV. So individuals that are of female gender, have a past history of PONV or motion sickness, are of younger age, and are non-smoking are classified as being high risk for PONV. Other factors that can increase the risk include use of high volatile anesthetics, the use of nitrous oxide, the use of post-operative opioids, and whether general versus regional anesthesia was used, and the type of surgery conducted. There's conflicting evidence whether physical status, the presence of a menstrual cycle, the experience of the anesthesiologist, and the use of muscle relaxants contributes to this high risk. Supplemental oxygen, the presence of a nasogastric tube, perioperative fasting, and the presence of a migraine have been found to have no relevance to PONV risk. For the risk factors of being female, non-smoker, having a history, and the use of post-operative opioids, this increases the risk by 20%, with individuals having a baseline of 10% with no risk factors. Prolonged recovery time and decreased patient satisfaction can also occur. However, so prolonged recovery time and decreased patient satisfaction can occur with these. However, although those aren't significant to the patient's health, the previous can lead to patient degradation and death. And a longer recovery time and decreased satisfaction means that more money for treatments and less reimbursement can occur. Another thing is a theme that was identified was the impact and incidence of PONV. In PONV, this occurs 20 to 30% of individuals and increases with these added risk factors. Again, many people would state that they would rather pay $100 out of pocket and even say that it's more worrisome than post-operative pain. And antiemetics are typically used in treating PONV, but when these fail, complications can arise. And these complications include dehydration and electrolyte imbalances, all the way up to wound dehiscence and pulmonary aspiration. Again, prolonged recovery and decreased patient satisfaction can occur, and although those ones technically don't impact the patient's health, the previous ones can lead to the patient degradation and death. So what do the guidelines currently say? The most recent guidelines published were in 2014 by the American Society of Peri-Anesthesia Nurses and the Society of Ambulatory Anesthesia. The goal of these guidelines is, quote, to provide current and comprehensive information to practicing physicians, nurse anesthetists, anesthesiologist assistants, pharmacists, peri-anesthesia, peri-operative, and ward nurses, as well as other healthcare providers about strategies to prevent and treat PONV in adults and children undergoing surgery. The guidelines go through what I like to call an 8-step algorithm, with the first step being to identify high-risk individuals. The second step is to reduce baseline risk factors for developing PONV, and this includes using regional anesthesia if possible, avoiding the use of nitrous oxide, minimizing post-operative opioids, and providing adequate hydration. Avoiding volatile anesthesia and minimizing intraoperative opioids is also recommended. The third step of these guidelines is to administer prophylaxis using 1 or 2 interventions in moderate risk adults. This can include the use of propofol anesthesia, haloperidol, scopolamine, methylprednisolone, and even acupuncture. A mention of the lack of evidence for music therapy, isopropyl alcohol inhalation, intraoperative gastric decompression, the use of esomeprazole, and the use of 7 milligram nicotine patches administered to non-smokers was mentioned as well, with the nicotine patch actually increasing the incidence and severity. The fourth step is to administer prophylactic therapy with combination interventions and multimodal therapies in high-risk individuals. The fifth step specifically is discussed for children. The sixth step is to give antiemetics to patients who did not get prophylaxis or prophylaxis failed. The seventh step ensures that PONV was previously, the prevention is treated and occurs in the clinical setting. And the eighth step is to, quote, use general multimodal prevention to facilitate the implementation of PONV guidelines. So why are the guidelines important? The guidelines used to mention that aromatherapy was a rescue intervention, but currently do not anymore. But they do have acupuncture, which is considered a non-mainstream therapy. So options may be limited since aromatherapy isn't included. The theme of aromatherapy was also looked at, showing that aromatherapy has been used for thousands of years, including in Egypt, India, and it's even mentioned in the Bible. Aromatherapy is used multimodally, which includes inhalation, topical application, ingestion, or any of these simultaneously. It's also been shown to have been used in France for GI disorders and to prevent colonic spasms during colonoscopies, and it's hypothesized as being a valuable complementary and alternative therapy for many conditions such as PONV. So what do the results of the study show? Generalized results, meaning aromatherapy in general, were looked at by one literature review and one systematic review. The literature review found that aromatherapy led to faster relief compared to the use of ondansetron, a significant reduction in the rate of PONV in patients, but a mixture of results in gynecological patients. The author stated that it was effective but should be used as a complementary therapy. However, the systematic review stated that aromatherapy was not effective after 3 minutes after administration compared to saline, water, or controlled breathing. They suggested that the increased attention with aromatherapy may be to blame, and this also leads to higher satisfaction. Peppermint oil was examined in 7 studies, including the systematic review previously mentioned. 4 of those studies found it to be ineffective. One study suggested the benefit was also with controlled breathing, suggesting it as a complementary therapy, with 2 studies stating it could be a first-line therapy in cardiac surgery patients. Ginger oil was examined in 4 studies, with all of them showing positive results in PONV relief. One study reported that 80% of patients had no complaints of nausea with less than 20% of a failure rate compared to the control. And another study suggested that it could be used as an alternative therapy in post-nephrectomy patients. Lavender and rose oil were both studied once in the same study, and the authors found that lavender did have benefits for postoperative nausea and vomiting relief, while rose oil was no better than placebo. Isopropyl alcohol was looked at in 4 studies and was also mentioned in 1 literature review and the previous mentioned systematic review. 2 of those studies found that IPA, or isopropyl alcohol, had significant results. 2 of them said that it was insignificant, and the literature review and systematic review showed that isopropyl alcohol had mixed results in studies. Of the positive results, 50 to 83% of patients had a reduction in symptoms in half the time compared to ondansetron, but there was no difference after 5 minutes compared to placebos. Although the authors did say that this option was more cost-effective at being 10 cents per pad, and it's also safer compared to antiemetics. It should also be mentioned that the authors noted when aromatherapy failed, so did antiemetics, except for IV ondansetron. The last aromatherapy that was looked at were oil blends. So 5 studies looked at blends of oils, with 2 of them being a commercial product called Queasease, which is, quote, a personal inhaler sold that aids in the treatment of nausea for a variety of reasons. Queasease is a blend of peppermint, ginger, lavender, and spearmint essential oils, and in the studies it was found to be effective, led to higher patient satisfaction, and was even recommended as a first-line approach. Ginger, spearmint, peppermint, and cardamom mixtures were looked at in 1 study, and the authors found that it was effective and led to less antiemetic requests. Ginger, cardamom, and tarragon was also studied once, and it was found to be more favorable in patients who had a proemetic drug after anesthesia, with 50% positive responses otherwise. The last blend was peppermint and orange, and the authors found that there were significantly positive results in high-risk individuals included in the study. However, with those results, there are limitations to this. The first one being a lack of high evidence. out of the studies, only 2/3 of them were high level based off Melnick and Fino-Overholt's 2011 model hierarchy of evidence. Another limitation is that these studies had small sample sizes. Only 4 of the studies mentioned had over 100 participants, and overwhelmingly they were female, although this can be expected because of being female being a high risk limitation, but this also limits the generalizability of the studies. Another limitation is the risk that it really wasn't even the aromatherapy that led to positive results, but rather the personal attention. So the hypothesis is that more attention leads to more satisfaction and possibly lower nausea scores. The last limitation is the variability in olfactory sensitivity. And what I mean by this is that one individual smells may possibly differ from another person, and this can lead to different results. So for discussion, overall 15 studies showed positive results supporting aromatherapy efficacy. For peppermint oil, the evidence for it, there is evidence for its use and potential use, but more high evidence studies need to be done due to the conflicting evidence. Isopropyl alcohol also has potential, but again needs more studies to be completed. Ginger and Queez Ease, the blend, had overall positive results, but again, because of how many studies utilize them, more need to be done. From the other blends, since only 1 study mentioned them, again, if you could probably guess, more studies need to be completed about them. And the same goes for lavender and rose oil. Although lavender was found to be beneficial and rose oil wasn't found to be beneficial, more studies need to be completed. So because of these limitations and the mixture of results, it's difficult to conclude that aromatherapy shows efficacy in being an alternative or complementary therapy in postoperative nausea and vomiting relief. However, it is a safer and more cost-effective option compared to antiemetics used today, and it also leads to higher patient satisfaction when used. So why is this important for nurses? As nurses, we provide safe quality care to patients in any setting. And often whenever we're providing this care, it's based off of evidence-based practices to give the best care for the best outcomes. And often these evidence-based practices include guidelines. However, when new evidence becomes available, guidelines change. So if the evidence shows that aromatherapy can be effective, nurses would be able to use it if placed in the guidelines. So because of aromatherapy being safe and more cost-effective, nurses could benefit from its use in high-risk individuals, leading to more satisfaction in a safe manner. So in conclusion, it may be beneficial for PONV relief in adults to use aromatherapy. This is completely dependent on the oil or the scent to be used. However, it is safer and more cost-effective than methods in the current guidelines. Aromatherapy would be beneficial as a complementary therapy. However, more studies need to be done to suggest it as a first-line or alternative therapy. Are there any questions?
We'll open it up to faculty and students. And do you have questions or comments that you would like to direct to Jourdan's way?
Hi, it's Dr. Laskowski. Jourdan, I do have a question for you.
Yes.
So after completing this literature review, now how will you use this information going forward?
So, as me personally?
Yes.
Personally, I probably won't. This is just based off the fact that I know I'm going into the emergency department, and unless there are patients who are coming in 24 hours after surgery, which I would expect them to either be on a med-surg floor potentially, or even in the PACU at that point, I won't necessarily be dealing with any of the postoperative nausea and vomiting. But if I were to transition into a different area, such as, again, the medical surgical floor or a gastrointestinal floor, it's definitely possible to where I could present these findings or even suggest it as a potential new intervention to be used on that floor and try and get results and see if it helps at all and lowers the cost of treatment in the hospital.
Okay. So what about like in the pre-surgical, pre and post PACU and stuff? Well, is there anything that you could recommend for them?
I would honestly have to look specifically. I'm sorry. What'd you say?
Nothing. I just asked the question about PACU and such. And
Oh, I thought you cut off. So you said for the PACU, right? Not pre-surgery?
Either one.
So for pre-surgery, I'm not entirely sure whether it would be beneficial or not. this literature review pretty much looked at post-surgery, but in the PACU at least, because of how cheap it is, as well as the low side effects to really no side effects, I think it would be beneficial to where it possibly could be used as kind of like we can try this. If it doesn't work, then we have rescue antiemetics sort of thing, if that's kind of what you meant.
I know that Kim Paver was on, and where she came from, I think they actually used this. And she was at first thinking of a DACO project on this.
I'm sorry, I can't hear you.
Oh, you can't?
No, it was muffled and then cut out a little bit.
Okay, it may be because I'm holding my computer. Kim Shaver, I think, is on, and she is a DNP student.
Okay.
And she was at first looking at doing this for her DNP project because where she worked before she came here, I believe they used that in their pre and post-operative area. Kim, are you still there? No. Okay, she must have checked off. But anyway, she wanted to do it here, and it was very hard to find a buy-in to permit that. So she uses it back home. I think she's from Mexico. I can't remember, Kentucky, somewhere like that. And they had used it, and she said they'd had good results from it.
Yeah, I mean, as I said, it was 16 of the studies found that it did have significant results.
Mm-hmm.
The one thing I would want to say about the side effect profile for this is there weren't any side effects listed whenever it came to the actual inhalation of this. So typically the aromatherapy was placed on like a gauze pad or a cotton ball and then swept under the nose. However, if you were to place the oils on the skin topically, there's always that chance for irritation, which would technically be a side effect. So it honestly depends on the administration of it as well. But overall, it is essentially safer side effect profile wise compared to antiemetics.
Great job.
Great job, Jourdan.
Thank you.
Excellent. So if nobody else has any further questions, we'll just offer Jourdan our congratulations, and we'll look forward to seeing you this summer, Jourdan.
Thank you.
Good job, Jourdan.
Good job, Jourdan.
Good job.
Jourdan.
Jourdan.
Good job.